Andrew Corbet Nolan, Chief Executive of the Good Governance Institute. Andrew.
Hello, good afternoon. Nice to see everybody. And what I'm really going to talk about is how we got here today. By the way, just to the last presentation, I think GGI's worked with every organisation up in Lancashire and South Cumbria, and that indeed is where I'm a professor, actually, at University of Cumbria. I know the patch well, and it is very impressive how they've moved things on as marathon runners rather than as sprinters. So how did we get here? Well, I suppose it was history and events. So I think firstly, we need to agree we're not really where we want to be or need to be. And there are various reasons for that. And in a system such as ours in the UK, where the majority of healthcare and much of the funding of social care comes from the government, you have the issue of the short-term political cycle, which doesn't prosper well things which have serious-minded and longer-term solutions. And also the fact that certain bits of that healthcare provision has a sort of more votability about it. So targets very much drawn towards things that matter to voters, like waiting times and you know, all the A&E stuff, rather than necessarily where the attention needs to be. And what gets measured is what gets done. So it sort of pulls the system into a very short-termism mindset. And of course, then we have the problem of investment not keeping pace with healthcare inflation, which is higher than usual inflation for various well-rehearsed reasons. And as the world gets older and sicker and fatter, of course, that even healthcare inflation is then outstripped by increases in need and demand, and a system which addresses symptoms rather than causes of poor health, as has been said already by other speakers. So we've ended up with a model which is really out of time now, and I'll just look at certain features of it. So the first is the sort of the model of primary care, with some laudable and notable exceptions, is that you get 10 minutes when you're sick. So that's the kind of model that we still largely have. Now, there are laudable exceptions and attempts to break out of that, but that's not the most, you know, the best way of keeping populations well and healthy and helping them navigate their way through complex health and social care systems. And the second is, of course, you've got funding incentives, which are very, very disparate. So if you take a sort of continuum from self-care through to then caring for people in their homes and supporting people in their homes, to then people needing to live maybe in residential or care homes of one kind or another, and then a hospital, you've got the first three are provided by sort of self-funding, and the last one is provided, 100% is paid for by the state. So you haven't got these sort of joined up incentives for shifting out of the most expensive and towards the cheapest. It's not all in one person's hand. Then, of course, you've also got the very hospital-based model, and it's a fallacious idea that in a complex health and social care system, that any one actor like the hospital can solve all the problems. And again, this speaks to a model that's well past its sell-by date. So then let's look at what might be done in the bigger term. And the theme as the webinar progresses will be very much about finding where the value is and focusing on that. And so I'd like to introduce you to the concept of value creation. If you think of the responsibilities of leaders through good governance, we would say that principally boards are intended to have 4 impacts. 3 of them we can move past quite quickly. So, you do governance well and work well as a board, you have legitimacy, you have an ethical culture, you have a tight control environment, but also you create value. And that quadruple sort of impact statement of what good board leadership does comes from Mervyn King Committee work on corporate governance. And what's interesting is the fourth one, value creation, was previously called good performance. So what is value creation? Well, it's what organizations or enterprises do that is above profit and performance. So it's the value they create and put into their local communities, society, that is beyond the initial sort of what it says on the tin of making surplus or profit and executing performance. And if you think to the model of how healthcare is judged, particularly by politicians, that does look very much at just performance rather than real value. We then have to think about how we can define and consider and measure value. And other speakers will be going into this in more detail. But I'm going to refer you to the model you probably, many of you know, called the triple aim. Well, I don't think it is a triple aim in the UK in 2025, but the triple aim is a concept which comes from the United States of America. And the triple aim there is that if you do things well, you get better care and patient experience, then you have improved outcomes and population health at a lower cost. But of course, in our system, you want more than just those three things. So what you also want to do is reduce health inequalities, which is not really such a feature of the American system, and be really serious about that. And then the final thing, because the funding for the healthcare bit mainly comes from the state, you want the well-being and sustainability of healthcare providers. So you want fit organisations that can contribute to systems and indeed work above their pay grade by contributing to the system. So we should really be looking for value in all those areas, in all those 5 areas, rather than just focusing on the very transactional, immediate performance figures. So let's then talk a little bit more about how leaders need to behave and act in a sort of more ideal system, and what the obligations of leaders are and what their duties are. And the NHS has really tried this. It's tried it through many of its policy documents, and indeed in some of the ways that there are governance responsibilities on boards. So if you look at the Code of Governance for NHS Providers, or you look at much of the policy, they're very laudable, commendable aims about working for system good and system first. The problems are often that the consequences are not visited on leaders for their contribution or failure to contribute to the system. It's more on the performance of organisations. So we sometimes need to break out of that. But this ideal leadership would be one that very much talk to leaders acting as great corporate citizens and helping to prosper the fortunes of others other than themselves. So moving into a world of what Mervyn King would call collaboration and compromise. And compromise is suddenly putting other people's needs above yourself because it's for the greater public good. And of course, the litmus test of that is, does it contribute to the value created in those 5 areas of the triple or quintuple aim? Does it reduce health inequalities? Does it prosper better health and social care providers that are more sustainable? Can we achieve this within a lower cost envelope? Can we do this in a way which improves the health and opportunities of the population, and for those who do need care services, give them better care and better patient experience? So we're moving into a new political phase. We're in a very different world than we were before the pandemic, and it seems to be getting more and more peculiar as the days go on, and less certain. And, we're talking about anticipating things like a war in a couple of years' time. So for those charged with keeping the population healthy and providing health and social care services, we've got the opportunity of the government's 10-year plan. Well, I do suggest it probably does need to look like old wine in new bottles. And old wine is rather nice, is it not? Because actually the consistent policy diktats about sort of recognizing the tsunami of need coming and, addressing healthcare needs higher up the value chain, and thinking about empowering people to be more prudent guardians of their own health and welfare. We've all known that for a very long time. What the 10-year plan, I think, does need to include in my book is actually changing the incentives to make it easier to do the right thing. And there's a good definition of governance. Good governance is it makes it very easy to do the right thing and harder to do the wrong thing. And I'll leave you with a sort of thought about the system we've ended up having, and how we really do need to have stronger focus and stronger forces to help people do the right thing rather than the thing that is sort of immediately asked. It's as if we nationalised the banks and we said, okay, the banks belong to everybody, and we're going to give everybody as much money as they need, and we're going to give everybody a cash card. And if you need cash, you just go to the cash point and you take it out at the point of need. It's there for you, regardless of your ability to sort of pay it back, because that's really what the health service is like. Every time you interact, you're spending money. Every time you interact with the health service. So in this model, we want to be sure that people are prudent with their money, because there's only a limited amount of it. And so what we're going to do, we're going to produce a few leaflets on prudent budgeting. And still, if too many people are going to the cash point and the cash point's getting empty too quickly, what we'll do is we'll start to close cash points down, and people will have to queue for the cash point. And we can only take 50 quid out at a time. So, they'll go back and join the queue again. And that, of course, is a pretty good analogy of how it is for health services at the moment. And we've got to do better than just some good budgeting advice. We really do need to think about a new social contract. The problem you get to then is very difficult conversations about the deserving and the undeserving sick, and we need to be very careful to avoid that kind of palette of language. So I think I'll leave it at that.
Thank you, Andrew. And really interesting. I'm going to ask you one question because we're a little bit behind time, but I'd just like to get one question. To drive those system behaviours, those changes that you're talking about, the different ways that people could and should operate, be incentivized, etc. If there was just one thing that you could put into the 10-year plan, what would it be?
It'd be Andy Burnham's old idea of a national care service. And I'm afraid I'd believe in governance rather than cabinet government by local authorities. So I'd put social care and social fair funding under the stewardship of the NHS.
Thank you, Andrew. I'm sure there'll be plenty of questions around that